Tantor Audio, a division of Recorded Books, presents Treating Suicidal Clients and Self-Harm Behaviors, Assessments, Worksheets, and Guides for Interventions and Long-Term Care by Meagan N. Houston, Ph.D., S.A.P. Narrated by Madeline Mccray. Publisher's Note: this audiobook includes bonus material. Please visit Tantor.com and type Treating Suicidal Clients and Self-Harm Behaviors into the search box. Follow the link to the book's page. Then, under the Supplemental Content section, please enter the access code HEALTH, and then click the Unlock button to access the bonus material. The code should be entered in all lowercase letters. All worksheets, checklists, and samples referenced in this audiobook can be found in the bonus material. Who this workbook is for and how to use it. One of my first difficult clients cut himself for years and had multiple suicide attempts with lingering suicidal ideation. I had never worked with this kind of client, and I was scared. Talk about sink or swim. I thought I was asking the right questions about previous attempts, current ideation, family history. All of those things they teach you in class. I was consistent with treatment, and I provided structure and boundaries. It was working. Then I got the call. 2 days after I'd last seen him, he'd attempted suicide. He'd cut his throat and was in the hospital with 289 stitches. On my watch, under my care. It was my worst nightmare. Where did I go wrong? I missed the subtle cues, the ones that may not necessarily be taught in the classroom, but that are critical for successful outcomes. Since that time, I have learned to be creative in treating my suicidal and non-suicidal self-injurious NSSI clients by personalizing strategies. I've developed a successful suicide risk training program that has saved lives, and I've built an integrated assessment instrument that has become the standard of care for my organization. I've effectively put these principles to work with many at-risk groups, including kids and adolescents, veterans, and military personnel, LGBTQI individuals, the elderly, police personnel, and prison populations. How about you? Are you prepared? Do you have the best tools to fight these battles? Imagine a flower. It's delicate, looks to be thriving and healthy, but if you look closely, it's not perfect. Subtle changes are happening that can go unseen if we don't remain vigilant. The presence of suicide and self-harm can also be elusive in the same way, lurking right underneath the surface of what appears to be normal and blooming. Treating suicidal clients and those who engage in self-destructive behaviors is not easy. There is no one right way to do this. Many clinicians feel confused or helpless in the face of severe behavior or consequences associated with these types of clients. Clinicians become fearful, anxious, uncertain, or overly cautious when treating these clients, and at times these feelings can lead to countertransference, negatively affecting treatment. We are not always prepared for the complexity of concerns associated with working with clients who present with suicidal behaviors, and this lack of preparation hinders our ability to provide adequate and effective care to our clients. Working with these types of clients can be intimidating, not only for the fledgling practitioner, but also for those of us who have continued to provide mental health services to clients who consistently present with suicidal behaviors. Given the intricacies that affect our clients' choices to live or die, it is difficult to pinpoint just one effective tool or technique that will fix this problem. Each client will be in a different place with respect to intensity of suicidal ideation, intention, planning, and even attempting. And clients typically do not fit into nice, neat categories. This workbook is designed to help clinicians understand the underlying etiology, varying life factors, and mental health concerns that influence suicidal and self-destructive behaviors. It is designed to assist mental health care providers in thinking critically about their clients' presenting concerns and understanding how cultural, environmental, social, and genetic factors play an enormous role in why our clients are thinking, feeling, and behaving in maladaptive ways. This workbook has been created to help you identify those subtle factors that may be key in the prevention of suicide for a client. As a result of the integral complexity of the presentation of suicide, there are multiple approaches a clinician can use to assess, manage, and treat suicidal clients and clients who engage in NSSI behaviors. This workbook is designed to provide assistance to the treating clinician who may feel impeded, frustrated, or out of options when working with this multifaceted group of clients. Topics, areas that will be covered include discussing suicidality with a client, assessing for suicidal potential, understanding suicide prevention with special populations and the mental health diagnoses that have the highest risk for suicide, using multiple therapeutic approaches, including interpersonal therapy, crisis management, cognitive behavioral therapy, and dialectical behavioral therapy. Chapter 1: Suicide: What You Need to Know. What is suicide? The Centers for Disease Control and Prevention defines suicide as death caused by self-directed injurious behavior with an intent to die as a result of the behavior. The dictionary Merriam-Webster defines suicide as being or performing a deliberate act resulting in the voluntary death of the person who does it. No matter the definition, suicide is an occurrence that is preventable when our clients allow us to help. However, we need to be articulate in our conversations in order to accurately interview, assess, and manage suicidal clients and clients who present with suicidal behavior. We also need to recognize and acknowledge our own fears, anxieties, and possible lack of training in the application of management strategies for these behaviors. Suicide is a topic that most people view as anxiety-provoking, taboo, and scary. It is a very real topic, and yes, it is frightening. But there are things about suicide that clinicians know that clients are unable to see due to their constricted and, at times, hopeless and helpless worldview. It is a phenomenon that must be addressed candidly and openly, and it is an issue that will be found in every clinical and non-clinical setting. Suicidal behavior can look like many things. It can look like self-destructive behavior. For example, that is, frequent drug use, driving recklessly, and/or placing oneself in dangerous situations. It can take the form of non-suicidal self-injury and accidental suicide, or it can present as more blatant self-harm behavior, as in cutting, taking medication in excess, or swallowing objects. Suicidal behavior can be impulsive at times, or it can be more rational and well-planned. Impulsive suicide. An impulsive suicide often involves the combination of a precipitating event, diminished coping ability, and feelings of helplessness, hopelessness, shame, guilt, burdensomeness, and feeling trapped. A precipitating event can include issues such as notice of a terminal illness, death of a loved one, loss of a job or financial stability, the breakup of a relationship, failing grades, or rejection. These events typically can make the risk of suicidal behavior imminent in the upcoming hours, days, weeks, or months. These events are typically sudden and involve crisis types of reactions. Drugs and alcohol are typically involved when a suicide is impulsive, as these substances lower inhibition, increase impulsivity, and compromise rational thinking and decision-making capabilities. Impulsive suicides are seldom accompanied by the classic warning signs, such as prior suicide attempts, diagnosed mental illness, or drug and/or alcohol abuse. The act is sudden and unrehearsed, and is thus especially more common among adolescents and young adults who are already biologically primed to be more impulsive. Clinical studies about impulsive suicide have varied, but some common characteristics of those who complete this type of suicide have indicated the following. Gender, typically male. Age, adolescents are at increased risk. Emotional immaturity. There is a diminished ability to think through consequences. Mental illness. Increased prevalence for psychosis and alcohol and/or drug abuse, but not for depression. Method. Considered medically severe, jumping into a body of water or throwing oneself into oncoming traffic from a certain height, jumping off an overpass into traffic, are highly correlated with impulsive suicides. Other factors. A history of aggressive behavior or of previous impulsive suicidal behaviors. Cutting, other self-destructive behaviors, and a history of poor decision-making. Rational suicide. Rational suicide has been defined as suicide in which there is a reasonable choice to die by a terminally ill person. It is also the ending of one's life for considered reasons as opposed to emotional or psychological reasons. Those who support rational suicide argue that there is a need to respect an individual's autonomy, meaning their right to be their own person or being able to act according to their own beliefs or desires without interference from others. The right to die is often viewed as an expression of the most extreme form of autonomy, which is the right to choose the time and manner of one's own death. Another view that supports the concept of rational suicide involves the ability of an individual to make a rational assessment of the utility or benefit that is gained by ending their life. Proponents of this view argue that suicide can provide escape and freedom from painful and hopeless disease. This view emphasizes the importance of quality of life rather than just living. Physician-assisted suicide describes the process of facilitating a patient's death by providing the necessary means and/or information to enable the client to perform the life-ending act. For example, the physician provides sleeping pills and information about the lethal dose while being aware that the client may commit suicide. This type of suicide is usually reserved for individuals who are currently living with terminal illnesses that are progressive and debilitating. As of September 2015, physician-assisted suicide is legal in California, Montana, Oregon, Vermont, and Washington State. Common elements of suicide. A common purpose of suicide is to seek a solution. Those who are contemplating suicide usually feel as if they have exhausted all possibilities when attempting to solve problems. Typically, suicide is conjured when experiencing a stressful situation for which they have no coping ability, or when attempting to navigate a situation that is out of their control. A common emotion in suicide is hopelessness or helplessness. Research demonstrates that hopelessness and helplessness are typically accompanied by feelings of shame, guilt, burdensomeness, inability to cope, and intermittent insomnia. This combination of symptoms can increase one's suicide risk, and the eminence of suicidal behavior should be assessed when these elements are present. These symptoms are also prevalent in most mental health diagnoses, including depressive disorders, anxiety disorders, bipolar disorders, psychotic disorders, eating disorders, trauma and other related stressor disorders, obsessive-compulsive disorders, and even substance-related mental health disorders. A common stressor in suicide is a frustrated psychological need. Frustrated psychological needs vary and are subjective. These needs could include the need for belongingness, financial needs, relationship needs, esteem needs, or safety needs. These needs are typically not being met, and most individuals feel as if there are roadblocks and other factors out of their control, impeding the satiation of these needs. The intensity of this frustration varies for each individual and in relation to the most recent issue or precipitating event. A common goal of suicide is cessation of consciousness. When suicide is being contemplated, individuals are typically seeking peace, homeostasis, and psychological and emotional congruence. They are seeking to end their existence in order to cease experiencing psychological and emotional pain. A common stimulus or information input in suicide is intolerable psychological pain. This type of pain is, again, subjective, similarly to frustrated psychological needs. Intolerable psychological pain refers to the inability to attain symptom relief from everyday functioning. This pain has been described as chronic and pervasive and is typically severe in intensity. It can be caused by various factors, including relationships, self-loathing and self-worth distortions, and feeling as if there is no end or logical solution to managing the pain. A common internal attitude in suicide is ambivalence. Ambivalence refers to the indecisiveness that accompanies suicidal behavior at times. Ambivalence is a good thing. When our clients remain ambivalent, they are uncertain about suicide and are more willing to discuss the issue. It becomes problematic when our clients move away from ambivalence and move closer to a sense of resolve about suicide. When resolve occurs, our clients do not typically give any indicators or warning signs about suicidal ideation or potential attempts. The common cognitive state in suicide is constriction. When our clients are contemplating suicide, they tend to view the world through a narrow lens and begin experiencing tunnel vision about their current situation. Feelings of hopelessness and helplessness begin to manifest themselves cognitively when this type of thinking occurs. Clients may view prior efforts as useless and future orientation as futile. This is why it is so important to instill hope and provide alternatives to the various situations clients experience. The common action in suicide is escape. When our clients are contemplating suicide, many of them are seeking to escape, flee, avoid, and/or seek a resolution to the problem they are experiencing. They want to be free of their current situation and are desperate to end their psychological, emotional, and at times physical pain. The common interpersonal act in suicide is communication of intention. Many completed suicides and attempted suicides communicate pain, agony, and desperation. Whether this communication involves writing a suicide note, writing another text, verbal communication, or behavioral communication, the sender is attempting to express intolerable inner psychic turmoil to a receiver. The common consistency in suicide is a history of unhealthy lifelong coping patterns. Most clients who present with suicidal ideation, intent, or a plan typically report a history of poor coping skills and becoming easily overwhelmed. They present with poor distress tolerance skills and poor emotion regulation skills. Chapter 2. Identifying at-risk clients. DSM-5. Diagnoses at increased suicide risk. A new feature of the DSM-5 is a specific section labeled Suicide Risk, which is included for select diagnosis. This emphasizes that individuals with these disorders may be at an increased risk for suicidal ideation, intent, or planning. schizophrenia spectrum, and other psychotic disorders and suicide. When working with clients who present with schizophrenia or other psychotic disorders, it is important to remember that these individuals, while not always dangerous, may present with suicidal ideation, intent, or planning. These ideas may be influenced by delusional content, feelings of paranoia, feelings of grandiosity, or feelings of invincibility. When an individual is experiencing actively psychotic symptoms, the risk for suicide increases as cognitive and affective impairment influence the person's behavior. When inquiring about suicidal ideation, intent, or planning with an actively psychotic individual, it is first important to remain calm and aware of their presentation. Are they agitated, restless, paranoid, or distrustful? If the client is presenting as agitated, it is most important that you first attempt to contact another clinician, if possible, and that you do not touch the client or physically approach the client. Continue to use your active listening skills and remain proactive in managing your safety. You can attempt to engage the client in deep breathing or other de-escalation techniques. It is also important to assess for the presence of auditory and/or visual hallucinations and to inquire about the details of these hallucinations. Such details are important because you want to know whether the client is experiencing derogatory and/or command hallucinations that are encouraging the client to harm him or herself or others, or whether the visual hallucination is dangerous or prompting of harmful behaviors. Disorders with increased suicide risk. Schizophrenia, schizoaffective disorder, bipolar or depressive type. Substance, medication-induced psychotic disorder. Psychotic disorder due to another medical condition. Schizophrenia and suicide risk. Research has indicated that 20 to 40% of individuals diagnosed with schizophrenia attempt suicide. Clients may act impulsively and without warning. During a psychotic episode, a client can present with unpredictable and sporadic behavior. This behavior cannot always be predicted or anticipated. It is important to keep this information in mind when conducting a suicide risk assessment, SRA, or engaging in treatment with an actively psychotic patient. Clients may be influenced by hallucinations and/or delusions. The client may be experiencing derogatory and/or command auditory hallucinations or other hallucinations, tactile, visual, and/or olfactory, that sway their actions and behavior. The delusions may also cause sporadic and dangerous behavior. Depersonalization can also occur. This causes loss of reality. Thus, during a psychotic episode, the client may not recognize that their behaviors are dangerous or life-threatening. Cognitive disruptions may affect decision-making. Paranoid ideation may influence behavior. Non-compliance with treatment increases suicide risk. The treatment of this disorder can be overwhelming for clients, as it involves a variety of methods including psychotropic medication management, intensive outpatient and/or inpatient treatment, and case management. There may be mood disorder symptoms, symptoms of depression, anxiety, agitation, irritation.
Sample complete. Ready to continue?